so I look forward to celebrating her.
I'll call you back.
Absolutely. Absolutely. Like I said, once Dr. Gomez comes online, he will chair the meeting. I'm just facilitating the IT needs of our Zoom call. So again, appreciate you all's patience.
Sure, thank you.
All right, I'm back in. So you said you're just facilitating, Antonio?
Yes, I'm going to sign off soon. As soon as Dr. Gomez comes back online.
Okay.
But are you on your phone or computer?
I'm on my phone. I'm walking.
Okay. All right.
You need me to do something?
No, just waiting for Dr. Gomez. I'm going to assign him the host of the event.
Okay.
So we're all set up, recording, doing AI summary. So just want to make sure as a point of taking meeting minutes that he has that all established and in place.
All right.
And just for everyone on the call, we do not distribute recordings. We just only use the meeting minutes for committee chair reports. So just to put that disclosure out front for you all.
Got it. Thank you.
All right, Dr. Gomez, can you hear me?
I'm still barely hearing everybody.
Oh, can you hear us now? Can you hear us now? Sky, you want to communicate?
Oh, yes, I can hear.
Can you hear Sky, Dr. Gomez?
Ellie. I don't think you can hear either one of us.
Oh, can you hear us now? Dr. Gomez?
I can hear everybody right now.
Oh, okay. Oh,
Yeah.
you can hear everyone?
Yeah, but I had to go off of my laptop. I don't know why this is happening, but anyway, I can hear people, so
Hey.
I will go with it.
Are you
Okay.
on, do you have a Mac?
No.
Oh, okay.
Okay. Hey, Dr. Gomez, I'm going to make you the host for the Zoom session, but we are up and recording and doing the AI summary. So your meeting minutes are being taken care of. So
Great, thank you.
All right, I'm going to make you the host. And if you have any issues, just give me a call.
Great, thank you.
All right. Have a
All
great
right, welcome
meeting,
everybody.
everyone.
Welcome everyone.
Welcome.
Thank
Welcome.
you
Hello.
for making the time. And thank you, Fred Delp, who I haven't run into at one of our clinics recently, for joining us and shedding some, giving us some insight on the state of our mental health services in the county. So I know that Jocelyn is going to have limited time. So why don't we start?
Just lost him.
Yeah, can't hear you. Ellie, I don't know if you're talking, but we can't hear anything.
Related activities and model those directly through outdoor gatherings, hikes, and events. And the objectives of the committee specifically are to promote a healthy lifestyle, improve our food choices, advocate for improving our resources in the county. We have a planned event at the end of the week on Saturday at Quiet Waters Park, hike. And I am not a marketer nor a promoter, as I think everyone has picked up by now. So any help that I can get getting folks out to Quiet Waters for the event, I sent a lot of folks a link, and we'll share it again with all the contacts here. And I'm hoping Pete Smith can make it from County Council. I didn't hear back from him as a confirmation. But why don't we start with getting the lay of the land and the way our delegate from District 21 sees it, because she's in a significant leadership role here, and has some is in a position to really give us an understanding of what we can do at a legislative level. Jocelyn?
So good evening. Thank you everyone for having me. It's can you hear me?
Yes.
Okay, it's really an honor to be here with you. I for some reason I'm not able to see you. I wonder what happened. But you are able to see me.
Yes, we are.
Yes.
Okay, that's okay. Here it comes. So it's great to be with you. As chair of the Health and Government Operations Committee, I want to tell you a little bit about what our focus has been in the General Assembly regarding access to care and what's going on at the federal level as well. On the General Assembly, our focus has been on protecting the Affordable Care Act, right? To make sure that we protect it, especially against what Trump is doing. So just to give you some perspective, before we actually created our own health exchange in 2011, and before we did the Medicaid expansion, our uninsured rate was actually more than 756,000 people in Maryland that didn't have insurance. In Maryland, we have presently 6.1 million people, okay? And we have 23 counties in Baltimore City, 24 different jurisdictions, 24 different health departments, local health departments, right? And we have Baltimore City as well for a total of 24. So before we created the exchange, we had that number of uninsured. After we created the exchange, and we actually expanded Medicaid because we were one of the early states that did that, our uninsured rate went down by more than 50%. That was more than 450,000 people that now could have health insurance, can have access to buying a policy. And the Maryland Health Benefit Exchange is really an amazing market where people can call, they have navigators, they can walk you through it, you could tell them what medication you have, and they can try to find, and give you referrals to the different insurance company, but they also will connect you to screen you for Medicaid as well. So it's all in one place. And right now in 2025, we have 1.5 million people on Medicaid in Maryland. Okay, so when you hear the conversations at the federal level, I want you to think about that. 1.5 million people on Medicaid. Medicaid is one of our biggest expenses in our budget, okay? And we have more than that 1.5 million, more than half of that are children, over 700,000 are children that are on it. What do you need to qualify for Medicaid in the state of Maryland? You have to live, for one single person, you have to live within 138% of the federal poverty guideline. What is that? That's less than $22,000 a year. Okay, so when you hear the discussion, we're talking about the very poor. In Maryland, we have a lot of waivers, right? Waivers are granted by the federal government for us to try different things, to be creative in Maryland, so that people can have care. One of the, I would say, one of our first and most significant efforts in order to get people covered in Maryland was the creation of Maryland's reinsurance program, which we passed in 2018. Why was that important? Because after we created the exchange, after we expanded Medicaid and we cover people, we discover that there were people that could not pay their premiums. So we created this reinsurance program, which was a bill that I introduced. I was the primary sponsor, that basically assessed a fee the insurance companies, the private insurance company, which we have right now, 5 of them in Maryland. And that fee was used to create this reinsurance program to help people that could not pay their premiums to reduce those premiums. And we have been able to keep, for the last, I would say probably the last 7 years or so, we have been able to keep those premiums low, right? And we provided stability for people that were in the individual insurance market. So they have been able to pay their premium, stay insured. Why is that important? Because if you have people that have Medicaid, which is the public insurance, or you have someone that buys insurance in in the insurance market and private insurance and they're covered, they won't go to the ER, right? Because the ER, the emergency department, is the most expensive care. And when they go to the emergency department and they don't have insurance, we all end up paying for it anyway. So, that legislation reduced premiums across the individual market and provided stability for nearly 300,000 Marylanders. It's a model that other states follow, and it remains one of the most effective tools that we have used to, keep coverage affordable. In 2020, when federal threats to the ACA again intensify, we passed legislation to codify the core protections of the ACA in state law. Why was that important? Because we decided if the federal government is going to get rid of those provisions, let's put them in Maryland law so that people can have the cover. So we codify a couple of things. We codify that Marylanders will not lose coverage for pre-existing conditions. We also make sure that people in their premiums had access to essential health benefits. We also require preventive services to be covered. What are those? When you go get cancer screening, right? Mammograms, all of that they be covered. OBGYN services, right? And we pass bills, laws to make sure that the pricing was fair, right? And that the law ensure no discrimination based on health status, on race, gender, sexual orientation, or disability. We also make sure that there was no lifetime, which is so important, or annual limit on essential benefits. If you get cancer, you could run out of that really fast. All right. So it was important for us to have that. We guarantee coverage for emergency services and prescription drugs, and we continue coverage for dependents up to the age of 26. So all those federal provisions, we put them in federal law as well. And these protections are now permanent in Maryland law. So what did we also discover, right? We did the exchange, we did the Medicaid expansion, we did this reinsurance for private insurance, but then we realized that young people do not have insurance. So recognizing that the high uninsured rate among young adults who, after a big accident, end up in the ER, we also created what is called a Young Adult Subsidy Pilot Program in 2021. And this targeted initiative provided state-funded subsidies to help Marylanders aged 18 to 34 to find affordable coverage. And it worked. Enrollment among young adults grew by 46%, outpacing every other group. So what does that mean in numbers? That more than 64,000 young people now benefit from this support. And this is meaningful, right? Because what we have seen, particularly in the Black and Brown communities, that the enrollment has gone up substantially. So this is why this year we passed a bill which repealed the sunset as a pilot and made the program permanent because it works. And if they're covered, then, we are all protected. In this session, I also put in a bill, House Bill 1045, which updates our laws to align with evolving federal protections, right? So when Trump came in, I brought in like 40 something people from the Maryland Insurance Administration, the Maryland Health Department, the Health Exchange, the advocates. And I said, what have we forgotten that we did not codify in Maryland law? So this is House Bill 1045 as well. So anticipating the expiration of those enhanced federal premium tax credit that people get through the exchange to be able to reduce those premium, and it has helped over 170,000 Marylanders afford coverage. We took further action this session with House Bill 1082. So the legislation allows Maryland to establish a temporary state subsidy program for the years 2026 and 2027 to soften the blow if Congress does not act. Why is that important? Because those subsidies are due to expire this December 2025. And if Trump does not decide, the federal government, to continue with them, Maryland is going to have a program to be able to do that. So each of these legislative steps reflect our commitment, my commitment, the General Assembly's commitment to the belief that health care is not a privilege, it's a right. And that right must be protected through thoughtful, proactive policy. So we're doing our part in Maryland. I am very, very proud of the work that we have done. So, we don't know what's going to happen with this big, beautiful bill that they did, which is really a big disaster of a bill. What is going to happen with the states, whether Medicaid is going to be cut. What does that mean? Are there going to be work requirements? Do we have to get rid of the expansion? Are they not going to cover for those services that the law provides as well? On our committee, we have also been very intentional on reducing the rate of maternal mortality in Maryland. Why is that important? Because Black women die at a rate 4 times higher than white women. Okay, so what we have done, we have been intentional about creating a maternal mortality review stakeholder group. We have been intentional about requiring a task force on maternal mortality and child health, passing bills on planning, on Maryland prenatal and infant care programs, having grants as well, extending coverage and access to low-income Marylanders. But most importantly, I introduced a bill, which I was the primary sponsor, that requires implicit bias training for all healthcare providers in Maryland. It was not easy because I had to get the doctors to come on board and many of the other health professions, because it requires them to take those continuing education classes. This session, even with everything that's going on at the federal level with DEI, I was able to introduce a bill that I was a primary sponsor that requires structural racism training for all healthcare providers in Maryland, because it is important that people learn about different cultures and biases as well. Another issue that I have been in my committee very intentional about is behavioral health. Behavioral health is very important. And I see you have the NAMI cap. I think that is what you have on, Frederick.
Yes.
And we passed, as you know, the bill that took 24 years to pass, and I was able to get it through last year, was a bill that put money, $3 million, and every year the governor promised to put more funding, money for a program that is titled Assisted Outpatient Treatment Program, which is a program, there's in Maryland about 700 people that end up in the hospital, in the courts, in the hospital, in the courts. It's the recidivism rate is very high. And some of them have been in the hospital like 50, 100 times. But they will be okay if they got treatment, if they took their medication. This bill does not force them to take the medication, but it incentivizes them that if they enter into an agreement that they will get care, then their court case, right, will go away. They will have some consideration with their court case. It focuses more on the care. Why is that important? Because behavioral health should be as important as physical health. There should be parity, is the law, but oftentimes there isn't. Insurance company, particularly private insurance, do not cover a lot of the services. So you will see bills that we introduce that actually require insurance coverage for a lot of these services as well. You know, when you talk about food, we have done some work around SNAP as well. And we, have focused a lot on health equity and health disparities. One of the bills that I introduced, which is really an important bill, is House Bill 78 of 2021, which created the Maryland Commission on Health Equity. And the purpose of that commission was to determine ways for state and local government to work collaboratively and to implement policies and laws to reduce health disparities and to increase health equity across the state. And every single secretary, there's 25 of them in Maryland, is required to design and create an equity framework. And the commission has to advise on racial, ethnic, cultural, and socioeconomic health disparities. They have to also develop a comprehensive health equity plan to address those social determinants of health and set goals for achieving health equity in Maryland. That commission is still on. A lot of you can volunteer if they have an opening to get on the commission. This session we also passed a bill that made permanent in law telehealth to be able to reimburse both for audio and visual equally as well. We have been very intentional about the issues that you care about. And Maryland often leads with these issues because we are created and we're not shy. I am not shy, and I'm very intentional about the bills that come out of my committee. We have worked closely with the Black Caucus on a lot of our legislative priorities to make sure that they pass. So I'm going to stop there because I can go on and on about the work that we have done. But there's still a lot of work to be done. And I know that the issues that you care about, I was going to advise you to work with the Office of Minority Health and Health Disparities. It's an office in the Department of Health, and it is tasked with addressing those chronic illnesses and to work on ways to reduce health disparities in Maryland. And they give grants, they do presentations, they work with different advocacy groups in the community. So I would advise you to work with them as well. And I'll stop right there. I hope that was helpful. I know it was a lot.
No, yeah,
Very good.
that's incredibly helpful. I think, can you hear me?
Yes.
Yeah, so I think it's important to have these protections in place. I am actually, very concerned at what the impact of cutting Medicaid funding or making it tied to, first of all, limiting the expansion, because you can't solve the problem when it's being pushed back the opposite direction. And so the ACA's already been hindered. But then tying it to work requirements is going to create a whole series of other problems,
Yep.
and which you alluded to. I think the level at which we operate, to be honest, is pretty sort of ground level. So our experience as a result of the larger legislative processes put into place and legislative initiatives that are put into place are protections that you're basically maintaining the status quo, and it's very appreciated. And yet, what folks are going to see, practically speaking, is that they're still going to be incredibly dependent on emergent care and overuse of emergency departments and urgent care. I certainly see it in both realms all the time from a clinical standpoint.
That's because we don't have a single payer, right?
Right.
You have and as someone who honestly believes that at some point we're going to have to get there, because either you are Medicaid, right, which is a state public insurance, or you are Medicare if you're an elderly, person over what is it, 65, or if you basically have private insurance, or you are uninsured. So, and then even when you have insurance, you have those high co-pays and you can pay for it or your medication. We are paying for prescription drugs in this country, more than 3 times, 4 times the price that most European and other nations are paying. We're subsidizing it. And we have the worst health outcomes. So, we can write a dissertation on this, and I'm sure many people have, but we know what the problem is and why people end up using the emergency room. Okay.
Well,
What we do
yeah,
here in
your
this
points are
country.
all well taken. I actually have published on this issue for a long time. It's
Yeah.
definitely not a new phenomenon, and the for-profit premise of our system is a very daunting problem. Yes, the most expensive care and the lowest return on that investment, probably in all of the developed world and in some of the underdeveloped world. So
Yep.
The um, the impact of these uh, changes, if we can call them changes, are really gonna, I think, push things towards a critical moment where so many people are going to be unable to pay for care. We're going to see
Yeah.
outcomes in mass portions of the population, not just the most needy folks, but many more people. And my other big concern, as I can see on the horizon, is that we are likely going to experience in the not too distant future another moment of pandemic and possibly avian flu crossovers, and that's not the only threat, but we're entirely not prepared. Not prepared. Public health was gaining a little something as a result of the understanding that without it, we would have never been able to respond reasonably to COVID-19. And now it's been debilitated by the present administration's choices at various levels, including at the research level, the NIH and CDC. So all that having been said, we're going to continue to fight the fight. The micro sort of that is what's happening in the county and how it's impacting our communities here locally. My thought is, and I expressed this to the executive committee and NAACP, as well as to basically anybody that'll listen, is that we have to, face the reality of what our resources are here. So, this is, for instance, this whole change of the big beautiful bill is going to devastate Arkansas. Most people don't know this, right? So many folks dependent on subsidized care are not in primarily inner city, poor Black or Hispanic communities. Tons and tons of poor white people in rural areas
Red states.
are not going to have resources.
Yeah.
It's going to be very sad to watch, but it's going to definitely cause a tremendous pushback. It's just a matter of time.
Elections have consequences.
Yeah, and so, but looking at it from the standpoint of what we can do here, I would like us to connect more on how the health department in the county is responding to what's going on here. One of the things that's salient in the county, you mentioned pregnant women, peripartum disparities. Infant mortality rates are persistent and huge in the county. And life expectancy gaps are significant in the county. And this is not all due to economics. As you point out, there's a good amount of cultural disconnect and cultural competence is a very difficult beast to tame because there is a sort of economic discrimination on top of a dismissiveness towards folks that don't have resources. And it's built into the system. It's built into the way managed care works, the way social work is made available, and then resources. Well-intentioned folks that are liaisons for patients in the emergency department in critical times for families with limited resources find that the first question is, and Mr. Delp can probably speak to this. We can get you a hospital bed in a more timely fashion. What insurance do you have? And so, if that question is answered in the negative, now you're sunk, because the limited lack of availability of mental health beds is really lack of availability to funds. The most affluent folks can always find care, but that's not the majority of folks that find themselves in this situation. Especially my experience when I see PEDS cases, and these are often families that don't have infrastructure, that don't have backing to be able to support those kids, and those are the worst cases, where they sit in the ER for like 2 weeks, 3 weeks, without ability to be placed or cared for. But before I
We
go,
passed a bill, if I may, this session, and it was my bill. And I don't know if you read about it. It's overstay. It's the overstay pediatric
yeah,
bill, and the hospital bill, where I literally threatened to boycott the administration if we didn't find the money for it. So there are kids that don't stay 2 weeks. There are kids that stay there 6 months, as young as 6 years old, right?
yeah.
So I've been working really hard on that with the department as well. So there all these issues are very true.
Well, we appreciate that, and I think that should be broadly, understood or passed on to our membership as well. I'm glad that we're recording this so that it's available for them, because a lot of them have kids, and some of them are very much, caught in the crossfire of this situation. But before I go on, I want to hear from Sky, who has her hand up.
Thank you. And I'm gonna keep my camera off. I'm out walking. But I had two questions, but I just want to make sure I heard you correctly on the first of all, Jocelyn, thank you so much for being here. Thank you for the wealth of information. I truly appreciate that. Now, did you say that the children will spend more, sometimes 2 weeks and months in the emergency
Yes.
room? Is
Yeah.
Absolutely true.
So what happens is that um, children that go to the emergency room for a particular problem, right? And they're sometimes taken in by their foster parent or a residential center, and they are stuck. They're left there because there's nowhere to place them, right? There's not a bed, especially when the kids are younger. It is very difficult to find placement for like an autistic child, to find that special treatment, that special bed. Oftentimes they find places out of Maryland in another state, which is more expensive. I mean, millions and millions of dollars. So we have a lack of behavioral health beds in the state of Maryland. The Department of Health and the new secretary, we met, they're very much aware of it. We passed some bills this session to help address that. We have a monthly bed registry meeting that I've been meeting for 7 years every month with the department. This is an issue that is very prevalent, but this session it got attention because it was just it came to a boil. It was just horrible. Some of the cases where the kids were there, I got a call from a nurse of a child that had been there 7 months. And I don't know how she got my number, but she called me. And then I call, and of course, they were able to find a bed. But you don't have to call a delegate or a senator to find a bed. It should be things that you have in place, right? For those beds have to be available. And then not only that, there must be, the hospitals have to work with a community to find services in the community as well. So it is a really complicated issue, but one that is getting a lot of attention. I have made it a priority, and
And
that was
understand
before,
that
way
this,
before my time.
yep, and understand that this happens, Sky, on a regular basis at the front line. So in the
Yeah.
emergency department, I'm trying to take care of a heart attack and a critical case and diabetic that's going to the intensive care unit. And at the same time as those cases are collapsing, I have a child who's not placed, who needs placement, who I've shopped around to multiple places. And I want to hear from, Mr. Delp, sort of his take on what's going on in this county, but just know that it's prevalent throughout the state, and it's a very common problem. One example that I'll give you is an
And I'm
oval.
sorry to say, I have 5 minutes.
Okay,
Okay,
and
yeah,
and
Okay.
I actually just I have to get off too, and those weren't even the two questions that I wanted to ask. It's just that it just threw me off when you mentioned the emergency.
yeah,
Do I
Yeah.
have time to squeeze in those two questions?
yeah. Go ahead.
Okay, so real quick, you mentioned structural racism being a requirement. Is that in effect right now?
That the structural racism, the governor signed it into law
Hmm.
about 2 weeks ago, and I believe it goes into effect this fall.
Okay, great. And then the other
And it's
thing,
for every single healthcare provider.
outstanding. And
Mhm.
then the other thing is you mentioned the emergency department being the most expensive. So how does that compare to these other facilities, for example, Patient First, and I think it's called nighttime care? How does it compare to that?
But that is when you go to patient first, you're seen, right? It's very different. It's a different system because most of the time you have insurance, right? When you go to those places, and some of them require that you pay cash to be seen and you see the doctor. And a lot of times in those places, you get your medication, you're out of there. The emergency department deals a lot with, with very like, heart attacks, very serious things. And not only that, a lot of people do not have insurance, and it's the uninsured that they get to see.
I'm going to be able to speak to that too once you have to depart because I'm a clinician for Patient First. But Mr. Delp, could you just quickly give me your most salient moment concern to share with Jocelyn before she has to get off?
Okay, thank you so much, Delegate Pena. Yes, I'm not sure how much of you all know about NAMI, so I won't go into that in a moment, but I'm going to give you a bright side. Now in Anne Arundel County, we have a mental health court.
I know.
Many of the
It
other
was very good, actually.
many of the other counties had mental health courts. We did not. We pushed hard, talking to them over the years, saying we need this. Other groups did also. It's not us, but we finally established a mental health court with Judge Jackson in charge of that. It started in June. So that's a good sign. A mental health court for those coming in that commit crimes or misdemeanors or whatever, that have a separate court system to go through. That's a really good bright side.
Excellent.
We're talking about beds in hospitals. We talk about this so many times. There's a gouge that says you'd have 13 beds for every 100,000 population. We use 500,000, 5 times 13. We should have 65 beds in our county. We have 40. We're 25 beds short for mental health psychiatric beds.
Yeah.
The worst part of that is we do not have one bed for an adolescent. All those beds that we have, the 40, are for 18 and over. Adolescence is where we're moving into right now with schools and everything, and the adolescents don't have one. If an adolescent goes in a hospital, voluntarily wants to be admitted or has to be admitted by doctor's orders, they've got to go to Shepherd Pratt way up in Baltimore or out of the state, Washington, D.C. area, somewhere else. We do not have one bed. Anne Arundel Medical Center, which has the place called McNew Center on River Road, that's their psychiatric beds. They have one floor with 16 beds. They have another floor on the third floor, completely empty. It's been empty now for 3 years since they've started. We've been pushing them to make that for adolescents or maybe geriatrics or a combination. They've refused, say money's not there, they don't have it. The state doesn't have it. I go round and round with them, but you're missing out on so much. But those are two big problems: beds in the hospitals, and second, psychiatric care. We do not have enough psychiatric doctors in this county. We're well short of psychiatric doctors.
In the state, in the
Yeah.
nation.
So one of my contacts in my softball leisure time, I connect with a caretaker for adolescents in Baltimore County, who says that their resources are so regularly overwhelmed. They have a straight line to Fox Chase in Philly. And so they're constantly trying to broker how to get the kid to Philadelphia from Baltimore, and it's absolutely crazy. The distance from the family, the inability for them to be present for any changes is untenable. So it's penny wise and pound foolish, or penny, scrimping on one side, and it's,
Yeah.
as Jocelyn points out, it's incredibly expensive on the backside. Because you got to do something with them. You can't possibly live in an emergency department. So this is what happens.
Yeah, we get so many people coming to our support groups, the parents of these adolescents crying, why is there no bed for my son or daughter? Why do they have to go all these other states or whatever? Look at the problems it causes, the money. The child's already in problems and he's half scared. They're going to send me to someplace I don't even know, and the parents can't visit or get to Philadelphia or whatever state, it's just, it's ridiculous. It's very difficult. And one other issue I have is money wise. People say in these hospitals, we make money on cancer treatments. We make money on these. We don't make any money on mental health. That's a shame. I can't believe they say these things. So
Yeah, the only way to do that is, as Jocelyn points out, is compel them legislatively, because they're not going to do it of their own accord. And managed care hides under the idea that they're providing higher quality, but what they're doing is providing guaranteed profit margin is maintained, and that's just been true across the board in every economy, because not everybody has money for cancer care or hematologic problems or any of the rest that falls into areas where there are limited resources with underinsured patients or limited coverage, and even folks with coverage, as we mentioned previously, and
yes, and for people without insurance, it's very difficult. Psychiatrists are charging $400, $500, $600 an hour, which is actually 30 minutes. People are lost. They don't have it. They don't know where to go, what to do. They come to us for support in our education classes, but we're not psychiatrists and therapists. We can't administer medicine, things like that. But these are some of the holes in the system that we go over and over with all the time. Thankfully, the mental health court, that one worked out. These other ones we're still working on.
So what other resources does NAMI have that we can connect to?
Well, we're primarily advocacy, training, education, support. Our education class, that's the big thing. We want to educate people about the mental illnesses, about how to go through them, where to go for resources, things like that. We partner with the hospitals, the mental health agency, the health department, the prisons, the jails, all these different things are partners, the providers that are out there all over our county. We partner with all these. So we provide education through our family to family class, our family support groups, our connection support group. That's one for those with mental health challenges. They have their own support group, and it's booming. We have 20 people come twice a month to that one meeting just for those with mental health issues that are over 18. And then our classes are booming too. When they're 25 people can max take our family to family class, 8-week course. It's maxed out all the time, 25. Our family support groups for the parents of the loved ones, they 18 to 20 people coming to all those. We've expanded from 2 to 5 groups in the past month. So many people come with problems, issues they don't understand, and we know the terminology. A lot of us have sons or daughters. I have a son with schizophrenia, bipolar, and OCD. We've gone through the system while we know the holes, the good parts, the bad parts, and we educate them. Education, learning about the brain, learning about the medicines, learning about the mood disorders, learning how to communicate better with someone with mental illness. Those are some of the topics that we discuss in our 8-week course. And so education, support, training, we'll train people and to help us do these. And the support groups, like any support group, people sit around and we all try to help each other about questions. They'll come and ask about the HIPAA law. They'll come and ask about AOT, just like Pena's delegate said. They'll ask questions. What are all these things? So we educate them as much as possible. We'll point them out to other resources of the mental health agency, or to a delegate that's really backing things if they're really into working hard for advocacy. So we do all these things: training, education, advocacy, and support.
But you have in Anne Arundel, you have the crisis intervention team, which is excellent. It's the best in the entire state.
That's
And,
correct.
and that is with the police department, with NAMI, and with the Anne Arundel County Crisis Response Team, and they do excellent work. I want to
We
leave
work,
you
we
on
work
a,
closely with them, and I have a CIT person on our board of directors. I
yeah.
want one on our board of directors so we know what's going on with CIT. I go and give them training too. The CIT officers that are getting new training about becoming a CIT officer, they invite me and I speak to them about NAMI, what we do, where we go, how we do things, and it helps them. For instance, when they go to a home where they have a crisis, they talk to them, say, you can go to, here's a card, go to the NAMI support groups, go to the NAMI education courses, things like that. So we work closely with them. Thank you.
Yeah, and I want to just leave you on a high note because I'm running late already. I was supposed to be there 7:30 and it's going to take me 25 minutes to drive there. I have to tell you that we are, I put in a bill that requires for the Department of Health to create a bed registry in the state of Maryland. And I think Dr. Gomez, you will appreciate this because I went with a constituent to an ER, which will remain nameless, who was 14 years old, who wanted to commit suicide. And I gave him and his mom a ride. I was there, I got there at 9 o'clock at night, and I was there like almost 10. I was there until 5 o'clock the next day in the afternoon. And once they made the decision after evaluating him that he needed to go somewhere, right, for 2 weeks or so for treatment, they couldn't find a bed. And the nurse will come and she will try to find a bed. And then she will go see a patient, come back another hour. And you went all the way to the bottom again. And she was calling Virginia, Hagerstown. I mean, I left when my husband picked me up the next day, and I'm not a crier. It takes a lot for me to cry. I was crying when I got in the car because I was so mad. And I didn't say I was a delegate or anything like that. And I could have made a call, but I wanted to walk in his shoes. So I put in a bill that requires hospitals to have, with the Department of Health, a bed registry to keep track of where the beds are in Maryland. I can leave you with this, that an RFP was issued and they're developing the program, and the hospitals with the 411, no, the 311, they have been working on, they have a team that specializes on working on those hard to place cases,
Yep.
and as well. So we're working on that. I can tell you that the Secretary of Health has been held, accused or threatened to be held in contempt, because the other issue that we're not going to get into it right now because it's a long discussion is people that are, incarcerated, right, and have behavioral health issues, and they really shouldn't be incarcerated. They should be getting treatment. And she has no beds. There's a lack of beds, so we're also now put together a work group working on that. And the courts are very interested in working on this issue. They just held a conference last week, a 2-day conference. So I know we don't have immediate solutions, but I could tell you that we're thinking about it as well.
Just know that from the standpoint of an advocate in the trenches, it's very frustrating to be able to do both things simultaneously, care for the other patients and do this. Just know that I'm all ears. Whenever you need help in trying to frame some of this stuff, I told you I'm interested in assisting with policy writing and all the rest. I'm available. Just reach out and we'll figure out how to support what you're trying to do.
I thank you, and I thank you for caring, right? For, you know, today on a Tuesday night at 7:28 p.m. 7:28 p.m. you're here after all of you having your full days. I know that you care, which is what gives me, energy to do this every day. And it's so frustrating because it is really the lack of money, always comes up, right? Not having the resources, but we do have resources for the things we want. It's all about priorities and being creative and making change, right? Even when it's not the
Sure.
popular thing to do, as well. But I often get in trouble for saying what I think, so I'm going to stay quiet. Um,
I think
and
good trouble, good trouble.
Oh, yes, but I thank you and consider me a partner. If this group's come up with some legislative, solutions and you want to draft a bill and you want to meet with me and you want to tell me about it and you can say, hey, Jocelyn, this is being done in Maine or this is being done in New York, whatever, California, or I'm thinking about this idea. What do you think? Let me know, okay? I'm definitely
Appreciate
not
it.
shy.
We appreciate your time too. Thank you so
Thank
much
you.
for spending this time with us.
My pleasure.
Thank
And
you.
thank you for listening to me. It's an honor, okay? To be with
Thank
you.
Keep up
you.
the good work. Thank you.
Thank you
Bye-bye.
very much.
You're welcome. Bye-bye.
Bye. So Fred, did you have some other gems to share? I know you invited me to consider joining your efforts there. I'm open to figuring out if I can make a
Yes,
contribution.
we're looking for board members. We've had a few step down after a few years. We're looking for a few right now, and I was trying to talk to you about it in our situation when I was up there at the patient care, but we could talk further about it. In the past, we've had a difficult time. I've been executive director about 7 years. I guess about 7 years ago, we had a difficult time getting African Americans and Hispanic people to lead our classes or be on our board, things like that. But now we've made great strides. African American 2 or 3 on our board, and Kia Chandler is our head of our board, is our president of our board. The Hispanic community, we cannot reach the Hispanic community. Nobody. We tried for years. People said, "I'll come and help. I'll come and help." We have everything printed out for them to use and everything. They just keep telling us that community is very tight and tries to solve it all. Don't want to let people know about their illnesses and their families. And that's our biggest problem right now.
It's a
Reaching
tough
the
nut to
Hispanic
crack
community.
because it's culturally coded as well, and it happens to a certain extent in the Black community. I think Sky would agree that we tend to sweep this under the rug.
Right.
But in the Hispanic community, it's very similar in that we don't want to acknowledge it. So and sort of run from the responsibility, even though we say we want to change it. It is very much a sort of kept at a distance, and it's very
Right.
frustrating. So I get what you're saying.
We'd like to partner with you. We have not in the past. Just wonderful. I ran into you. We partner with all those other groups, the hospitals and health department, providers and everything. Work together, exchange information. The providers will send people to our support groups, to our classes, but we would like to work with you guys, be a partner.
I think a good way to do it is just to draft a brief formal letter to Stephen Waddy, our president, and sort of summarizing that proposal. He's a very dynamic young dude and a brilliant guy.
He's the president?
Yeah, Stephen Waddy, Waddy. And you can use the communication on the thread that I sent you where your email appears. He's on that thread.
Okay.
And reach out to him directly through that. I know he's open to it and interested in connecting in that way.
And is that NAMI Anne Arundel County?
Yes. It's a national organization, headquarters in DC. Each state has a headquarters. Ours is in NAMI, Maryland, it's called. It's over in Columbia. But then each county has a own affiliate. We're the Anne Arundel County. The 5 biggest are Baltimore County, Howard County, Montgomery County, Prince George's, and us. We're all our own 501(c)(3)s. We're own autonomous. We take a little bit of training and things at times from NAMI, Maryland, but we are our own group. We sort of work together with some of them, but like all the courses I mentioned to you are the same if you take them in Hawaii or here or Pittsburgh.
Oh, I'm familiar,
Texas.
and I've sat in on behalf of NAACP in the past.
Okay.
But I do have to run, but thank you very much for being here as well.
All right. Thank you so much.
Yeah, well,
Take care.
we've reached the end of our time too. Sky does some work with sort of a more holistic global mental health, and
Okay.
also would be a great resource to connect with. So
Yes,
thank
thank
you
you.
for joining us tonight and being a part of this. And just know it's a recurring meeting, first Tuesday of the month at 6:30. We're going to do it again next month. And I think it's invaluable
question.
to have your input. Yeah.
How many run your health committee?
So there's about a half dozen of us formally, and then maybe a dozen informally that pop in from time to time.
Okay.
But the best way to coordinate it is through Stephen Waddy and Mary Dodoni, who sent you the link for the meeting.
Are you the head of the committee?
I'm the chair of this committee, of the health
Chair.
committee,
Right.
and the president and then the VP who was on at the beginning, Antonio, also is a huge resource for us. He's also on the thread that you got the link through.
Okay, so I'll write to him, introduce myself, and say we're interested in partnership and working. And if mention you as joining our board, I mean, thank you.
Excellent.
Have a
Well,
great night. Thank you so much.
thanks. You take care. Thank you very much for taking the time.
All right. Good night. Bye-bye.
Take care.